You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 26, 2024. Our topic is Primary Ciliary Dyskinesia. This is presented by Dr. Hugo Escobar. He's an associate professor of pediatrics and is the associate director of the Cystic Fibrosis Center at Children's Mercy Hospital in Kansas City, Missouri.
So yeah, today we're going to talk about primary ciliary dyskinesia. It's one of those topics that I think has changed significantly in the last maybe 5-6 years. Go ahead. Okay. I think we are finding out that some of the previous diagnostic tests were not as accurate as we thought, and new diagnostic tests have come to light. So it's really changing the way we see this disorder, and we feel that there is a lot of people undiagnosed, and that hopefully with some education and more highlights of the new test, we can start diagnosing better. So we are going to talk a little bit about the ciliary structure today. Whereas the clinical phenotype, and so also highlight when to suspect primary ciliary dyskinesia even in babies. What are the new diagnostic methods, as I was saying before? Some of the diagnostic of all the diagnostic methods, because we really don't have a gold standard test yet. And what are the available treatments? Just to start getting to know a little bit of the cilia, we have 3 different types of cilia in humans. The first type is what we call the nodal cilia, and this one is only present in the embryo and embryonic period. This type of cilia does not have the central pair, and therefore instead of beating back and forward, it actually beats in a circle. The importance of the cilia is that this is a cilia that is going to tell the organs where to go. So when the cilia is working fine, the heart is going to go into the right position, the spleen is going to go into the right position, the stomach. When this cilia is not beating fine, the organs can just go randomly either to the right or the left, and that's how you get situs inversus. We got the primary cilia, and this primary cilia is found everywhere in the body, in the ear, in the eyes, in the kidneys. Mainly function is, well, I guess it depends on the organ. It can have some absorption, if, for example, it's in the kidneys, or it can have some sensory function if it's in the eyes, for example. So it's really found everywhere, and different disorders of this type of cilia can cause different problems, like, for example, polycystic kidney disease is a ciliary problem of the kidneys. You can have biliary atresia, you can have spina bifida, retinal disorders. Again, it's very, very important type, but this type of cilia does not move. And then we have the cilia that moves, that is the motile cilia. This type of cilia is present everywhere from the middle ear all the way to your terminal bronchi. It's also present in the ventricles and in the fallopian tubes, and this is the cilia that moves. And when this cilia doesn't work well, that's what we call the primary ciliary dyskinesia. So primary ciliary dyskinesia is a congenital disorder that causes recurrent otosino-pulmonary infection. So kids typically present with recurrent ear infections, sinus infections, and also chronic cough. If we don't adequately pay attention and start treating, it can progress to hearing loss, bronchiectasis, and irreversible lung damage. Primary ciliary dyskinesia, it's complex because it can have, it's a defect of the ciliary structure, but different from other disorders. There are multiple genes that are involved. So for example, cystic fibrosis is a disorder of one gene, which is the CFTR gene. Whereas primary ciliary dyskinesia, we have identified more than 50 genes that can cause it. So this just highlights the complexities of the diagnosis and also all the different types of in the spectrum disorder that you can have when you have more than 50 genes causing this disorder. Now we know that more than 30% of people that has primary ciliary dyskinesia have normal ciliary structure. So this has significant limitations to diagnose PCD with electron microscopy, because at least a third of the cases will have normal electron microscopy, limiting this diagnostic test. And as we have been saying, we really don't have a gold standard, so that also makes it difficult, because then you kind of have to have a panel of different tests to be able to diagnose it. A little bit of history. I took this slide from the last PCD meeting. So the first description of a person with primary ciliary dyskinesia was in 1933, which was when we described Cartagener's triad. Then in 1974 is when we were able to start describing the structure of the cilia with the 9 pairs on the central pair, dynein arms and all of that. In 1999 is when the first gene was found that causes primary ciliary dyskinesia. And again, now we have more than 50 genes. I think we find maybe 2 or 3 genes per year, which is kind of amazing. In 2002, the Primary Ciliary Dyskinesia Foundation was funded, and this has significantly changed how we do things, because it has organized multiple centers in the United States to treat and diagnose and do research for PCD. And most recently, in 2004, the Rare Disease Act was created, and it's important because this also has increased the amount of research that is done, and not just for PCD, but also for other rare diseases, like a lot of immunodeficiencies too. So the motile cilia has the primary structure of 9 pairs with a central pair. You have your dynein arms, the inner and outer dynein arms, and the radial spoke. So defects in any of these proteins can cause problems in the movement. There is a power stroke, that is the one that is going to move the mucus out of the airways, and then the recovery stroke. So it's as you can see, there are multiple proteins in this cryo-electron microscopy, multiple proteins that can be affected, and that's what this is so complex. See if this is going to work. So this is the normal movement of motile cilia. Very nice and crisp, organized movement. And you can see actually some of the mucus moving on the top. So prevalence, it is very likely that it is a very underdiagnosed and underestimated disorder. Again, we were relying on electron microscopy to make the diagnosis, and now we know that a lot of people with PCD just have normal electron microscopy. So previously we thought that it had an estimated incidence of 1 in 20,000. A recent study that was published in Lancet, using some of the genetic studies and genetic information that we have, actually estimates that the overall incidence could be as high as 1 in 7,000. And they describe in this study that they tried to be conservative. They excluded the variance of non-significance and only included the genes that we currently know as having primary ciliary dyskinesia. But this is an estimate using a company's data information. But so I guess maybe the true incidence might be somewhere between 1 in 20,000 and 1 in 7,000. But it just highlights how underdiagnosed it might be. And I think some of the challenges on diagnosing primary ciliary dyskinesia is to try to find out when to suspect it. As you guys know, a lot of kids have multiple ear infections, congestion, and all of that. So when is congestion or ear infections more than what a healthy or normal child will have, and when it is primary ciliary dyskinesia, that's when it gets complicated. So manifestations of primary ciliary dyskinesia start in infancy, pretty much in the newborn period. So when we did some retrospective data reviews, we found that 80% of neonates with primary ciliary dyskinesia actually had a history of respiratory distress. The majority of these babies had abnormal chest X-rays, as seen here on the picture. They presented with atelectasis and an oxygen requirement. So most babies that have either respiratory distress or an oxygen requirement in the neonatal period are going to have likely transient tachypnea of the newborn. But the difference here is that in transient tachypnea of the newborn, you don't have atelectasis on the chest X-ray. You just have diffuse increase in interstitial markings with maybe some fluid in the fissures, whereas kids with primary ciliary dyskinesia are going to have atelectasis on the chest X-ray. So if you have a little neonate that has a history of needing oxygen for several days in the neonatal period, that was born full term, X-ray was abnormal, you have to suspect primary ciliary dyskinesia. Situs inversus is present in 50% of the patients, as we described. This is a defect in parts of the cilia that are also present in the nodal cilia. And heterotaxy is present in 6% of patients with primary ciliary dyskinesia. Babies, 1-2-year-old babies will tell you that these kids have daily nasal congestion that is year-round. So even in the summer months, they still have nasal congestion. And they start really, really early after birth. They typically say that like 1-2 months of age, the baby was already congested, having drainage through their nose. This is one of the maybe the first study that described the association between neonatal respiratory distress, neonatal hypoxemia, and primary ciliary dyskinesia. So as we can see here, when we have an oxygen requirement for more than 2 days and lower collapse on the chest X-ray, the sensitivity and specificity is pretty high for primary ciliary dyskinesia. The same for situs inversus. When you combine all three, an oxygen requirement of more than 2 days with situs inversus and or lower collapse, it gets even higher. So just to highlight the importance that if you have a baby when you're taking your history on a kid that has recurrent ear infections, congestion, drainage, if that child had a history of neonatal distress with an oxygen requirement of more than 2 days, and it's really not very clear why, you strongly have to try to rule out primary ciliary dyskinesia. Heterotaxy, it's present in 6% of patients. So, and all the patients that had primary ciliary dyskinesia in this center, about 46% were situs solitus, so the heart was in the right spot, in the correct spot. Let's call it that. They found that 47% had what we call situs inversus, which the heart rhythm was in the right side. Heterotaxy with all the variations was present in 6%. So the variations are kind of, you can have multiple different areas. You can have the heart, the bowels, and so again, things in the middle, asplenia, polysplenia, all kind of different things. And that's what makes that these kids, when you have an association with heterotaxy and primary ciliary dyskinesia, they have a significant increase in cardiovascular abnormalities. If you have a patient that has a heterotaxy, please remember to check for spleen. If these babies have asplenia or polysplenia, they can have functional asplenia, and they are at increased risk for sepsis. So all the patients that we have that we have diagnosis primary ciliary dyskinesia, we check for their spleen because we have to pay special attention, and there have been a few case reports of kids have a pneumococcal sepsis because they had functional asplenia. So as we were discussing, most kids will present with chronic otitis media, and that can progress to hearing loss. So we do hearing tests actually on our patients once a year. There are recurrent episodes of sinusitis and nasal polyposis. Almost all is universal to have kids with persistent daily non-seasonal wet cough. So they just, their chest just sounds full of mucus. They have recurrent bacterial pulmonary infections with chronic bronchitis that end up with resultant bronchiectasis. And almost all adults with primary ciliary dyskinesia will have a degree of bronchiectasis. It is common that kids just go undiagnosed until about 5 or 7 years of age. Ear infections are very common, and as we can see here, recurrent otitis media is present in the great majority of kids that are younger than 5 years of age. Otitis media gets a little better as kids get older, but chronic otitis media is still present, and as you can see here, even people that is older than 18 continue having chronic otitis media. Conductive hearing loss is very common too, and as you can see here, even adults have a significant degree of hearing loss. Other uncommon presentations of kids with primary ciliary dyskinesia. Kids can present with hydrocephalus. This is a rare complication, and it's mainly associated with specific genes. One of them is the one that we list here. Another representation can be sepsis, as we discussed, in kids that have functional asplenia and malrotation. In adults, they present with chronic pansinusitis and hypoplastic sinuses. They have progressive airway obstruction on pulmonary function test that as they get older, it keeps progressing. Almost all adults have a degree of bronchiectasis, and there is a decrease or reduced fertility in females with an increased risk of ectopic pregnancies in females, and almost all males are infertile. There are some exceptions about males being able to have kids, and these are the ones that have genetic abnormalities in the cilia that are associated with decreased number of cilia, because then they will have cilia, they just have decreased number. So there are a few exceptions to this rule. So not everybody that has PCD is infertile, not all males, but the great majority will be. This is a study that was done in North Carolina, and this is a look at their cohort of patients with primary ciliary dyskinesia and symptoms of cough, bronchiectasis, and also their lung function. So as you guys can see here, cough almost universal on everybody. Bronchiectasis, kids start having some bronchiectasis early in life, and then in adults it's almost present on everybody. Recurrent sinusitis and otitis media. So even adults still have some degree of, as we said, chronic otitis media is present. And pulmonary function test, it's in most kids have normal lung function, but there is a clear decline as people start getting older. With in this cohort, the median FEV1 was 60% of predicted for people that was older than 18 years of age. Respiratory culture. So as we described, these kids have a chronic bacterial bronchitis, and some of the most common bacteria, just what we're going to see on the airway, which is your Haemophilus influenza, Strep pneumo, Moaxilla catarrhalis. So early in life, those are the most common bacteria, but as they get older, they start decreasing. Their Pseudomonas aeruginosa, it's can be seen in younger kids. I think I have And we see it in 5-6-year-olds. It's easier to eradicate at this age, but as people get older, it's more prominent. And as you can see here, this green, which is the Pseudomonas, becomes more prevalent as people get older. Also, non-tuberculous mycobacteria happens. It's not super frequent, but we see it, and we test for it once a year on people that can produce sputum. Now that we have more spread genetic testing for primary ciliary dyskinesia, we have been able to just differentiate what is the course of the disorder depending on their defect and also their genes. So here at the bottom, it's a normal person with a normal electron microscopy. On A, this picture is are the people that has outer Danain arm defects. This group of people in green has outer and inner Danain arm defects, and the ones in red have inner Danain arm defects with central apparatus problems and also microtubular disorganization. So as we see here, there is a very slow decline on the ones that they have only the Danain arm defects, but it's present. But these kids here have a more significant decline. So now we know that people that has the inner Danain arm defect with central apparatus and a microtubular disorganization have more severe course with more infections and faster decline in lung function test. So we move to now diagnosis. We don't have a gold standard. We have several different tests that are available, and sometimes we just have to move through them to be able to rule out PCD. The only problem is that these tests are not available in all centers, and they're only available in specialized centers. And people that we have a strong suspicion, we have to do more than one test to be able to rule it out. Currently, we have tests that are available are the electron microscopy, genetic testing, nasal nitric oxide concentrations, functional ciliary bead analysis via high-speed microscopy, and less commonly done, but now we're starting to see more immunofluorescence. So we're going to start with respiratory epithelial cell biopsy with electron microscopy, which is the historical one that we have used for many years. We can do the biopsies from the nose or from the airway, either the carina or trachea or the bronchi. And this has been historically it's been a proven technique to diagnose PCD. It is a confirmatory test for patients that will have defects in the electron microscopy. So, but now we know that it's about 70% of the people. The normal structure is in the panel A, when you have your outer Danain arms in red, inner Danain arms in green, and all your radial spokes, and everything looks nicely organized. And we have them examples of people with primary ciliary dyskinesia and different defects. In B, you can clearly see that that patient is missing the outer Danain arms. In C, that person is missing the inner Danain arms. But one of the things that we'll discuss a little later is that this defect can be seen just with recurrent viral infections and not through primary ciliary dyskinesia. In D, we have clear disorganization of the macrotubular structure with tubules that are just everywhere. In E, we have patient that is missing both the inner and the outer Danain arms. And in the last one, we see how the radial spokes are just completely disorganized or missing in that patient. Just to clarify, this technique is very difficult, and trying to get pictures like this is rare. So that's one of the difficulties of this test is the processing of the samples and the interpretation. This was one of the descriptions of some of the first patients that had normal structure but clearly had primary ciliary dyskinesia. They described how patients with this mutation, the DNAH11, had everything for primary ciliary dyskinesia, but their ciliary structure was normal. So this started to highlight the importance of not just relying on this diagnostic test. In this interesting study, they look at people that had inner Danny arm defects, and the authors of this paper, they had 21 patients that had a diagnosis or at least abnormalities in the inner Danny arm defects, and 6 with the radial spoke defects. They decided to retest and redo the biopsies on all of these patients. And what they found is like 5 patients out of the 21 with the inner Danny arm defects and 1 with the radial spokes actually had normal electron microscopy when they retest. So now we know that when we see this type of defects on ciliary biopsies, we cannot diagnose the patient with PCD until we repeat the biopsy a few weeks later or when the acute episode of infection has resolved. And if we see the same abnormalities, then we can think that maybe they are a true diagnosis, but clearly some of these patients will just have damage because of acute infection and not through primary ciliary dyskinesia. To make things complicated, now we know that when we look at these proteins that can be effective in people with primary ciliary dyskinesia, these proteins might not be uniformly distributed in the cilia. So this is a nice example of how these 2 proteins, actually the DNAH9 and the DNAH11, are not present throughout the cilia. They are just present in specific parts of the cilia. So the DNAH11 is present only in the lower part of the cilia. The DNAH9 is only present in the top part of the cilia. So if you do a ciliary biopsy of this part, you might not be able to see the defect on the cilia because the protein is not present in that section. So this also highlights how some of the genetic defects might be in areas of the cilia that might not be present on the cut that was sent for analysis, highlighting some of the problems with this technique. So electron microscopy can miss defects with normal ultrastructure, subtle defects in the central apparatus, and repeated biopsies might be needed. Also, if a patient has a defect that that is associated with decreased number of cilia, we're not going to see any abnormalities because they will have a normal structure but just decreased number of cilia. Patients with isolated inner Danny arm or radial spoke defects need a repeated biopsy or a different confirmatory test. Early studies of misalignment of the central pair were thought that were diagnostic for primary ciliary dyskinesia, but now this defect is considered a secondary defect and not a true primary ciliary dyskinesia defect. Biopsies need to be delayed until at least 2 weeks after an illness. The only problem is these kids are sick all the time, so trying to catch them on a period of time that they have been fine for 2 weeks is really complicated. The test can be expensive, it's not available in all sites, and it can take several days to process. Now we move to genetic testing. So genetic testing has revolutionized the way we diagnose primary ciliary dyskinesia. It can allow for early diagnosis or patients that have had a normal electron microscopy analysis. There are more than 50 genes that are known to cause primary ciliary dyskinesia, and these are about 80% of all the cases. So we still don't know, on people that has confirmed primary ciliary dyskinesia, in 20% of those cases, we still don't know which genes are implicated. Most cases of primary ciliary dyskinesia are autosomal recessive, but now we know of some cases too that are X-linked. and that are them not autosomal recessive. The two most common X-linked ones that we find are orofacial digital syndrome and retinitis pigmentosa 2. This is a list of some of the genes that are implicated with primary ciliary dyskinesia and what their predictive defect in which protein it is. But as you guys can see here, the ones in red are some of the ones that are the most common defects. And in here, it says that normal electron microscopy. So this one, which is one of the most common ones, is associated with normal electron microscopy. Here we have some of the ones that are associated with, that are X-linked. These are some of the genes that are associated with a decreased number of cilia. So their structure will be normal, it's just decreased number. And some that we still just don't know very well. So different populations may have different genes associated with them, and this also then highlight is for some of the centers that might be doing a panel of genes. Depending on the population that you have in your country or your region, you may need to tailor that to the different genes. Actually, one of the things that I learned recently is that in Puerto Rico, there is one of the genes that's very common, and it's so common that they're actually starting to do newborn screen for PCD based on that gene, because it's just endemic to that area. But genetic testing also has significant limitations. These are some of the different tests that highlight some of the limitations of genetic testing. So here we have the first one. It says implementation of a gene panel for genetic diagnosis of primary ciliary dyskinesia. So as we discussed earlier, depending on the region, depending on which population you are dealing with, the panel that you select might not include some of the genes that are common in that person. Also, there are new genes that are discovered every year, and the panel that you use might not have been updated in several years, not including some of the most recently described genes. So panels are great. Usually they are fast, they are cheaper, but panels are not going to include all the genes because companies sometimes take some time to just update what they include in that. So just when you order a panel of PCD genes, just know what you're ordering and know what you're not. In that way, you can make an informed decision. Here we have diagnosis of primary ciliary dyskinesia via whole exome sequencing. So this is one of the most common tests that we're ordering now, which is doing whole exome sequencing that is targeted to certain symptoms or disorders, and we find that very helpful. Because then we can just test for recurrent sinopulmonary problems. So that would include primary ciliary dyskinesia genes. It will include some of the immunodeficiency genes. But some of the limitations of that is that we're going to have a lot of variants of unknown significance. And how do we interpret those? So that is always challenging because they can cause disease, they may not cause disease. So you may need a second test, or you may need other ways to diagnose it, especially in people that may have multiple variants of non-significance. You may create anxiety on the family when you have a lot of variants of non-significance that might actually be not causing problem, but now are reported. So that's one of the drawbacks of this technique. And then there are some limitations to exome sequencing, and it is that now we're starting to describe some not exome problems but intronic defects. So there can be people that has mutations in the intronic region that can actually have pathogenic mutations, and then so if you have a strong suspicion, you may need to move from whole exome sequencing to whole genome sequencing to be able to diagnose some of these problems. So we have one of the genetic testing limitations. This 4-year-old kid has autism, recurrent ear infections, chronic thick nasal mucus, no need for oxygen in infancy. So he was born without respiratory distress of infancy, has some mild cough, no pneumonias. Chest X-ray shows mild streaky subsegmental atelectasis. He is currently followed by ENT and infectious diseases. And when we did genetic testing, we found all of these genes. So again, when you do whole exome sequencing, you can find a lot of different things, but most of these are going to be variants of unknown significance. So what do you do with these? And there are several genes that were found in here that are associated with primary ciliary dyskinesia. So we have these two here, but they're both variants of unknown significance. So what do you do? Like, is this causing disease? Is this not? So that can make things complex because they're not really clearly pathogenic, but now you have two defects. So this the DNAH7, it's a gene that codes for a protein that is present in the inner DNA defects. So does this patient has PCD or not? So that's a complicated question. So since we knew that this protein codes is located in the inner DNA defects, we thought that if these two mutations were causing disease, then this patient will have to have abnormalities on ciliary biopsy in this area. We did a ciliary biopsy and it was completely normal. So we felt that these two genes were not really causing disease at this time. So this is kind of a way of trying to just clarify, but it also highlights how difficult it is. And in addition to that, we decided to do nasal nitric oxide to again be sure that these genes were not causing disease, and the nasal nitric oxide was normal. So pretty much ruling out primary ciliary dyskinesia in this patient. So mutations in genes that code for the dynegram defects are associated with laterality defects, whereas mutations in other genes may not. Another part of the problems with diagnosis with PCD with genetic testing is mutations in oligocilia. Now that we know that we were described before that these people may have normal structure, but also they may be fertile. So if you have a patient with a CCDC114, just be cautious to tell that person that they are not infertile. They actually can have kids. Variants of unknown significance are very common, and there's just not enough data to just know what the impact on the protein is. Intronic mutations can cause disorder, and this can also complicate some of the diagnosis. And there are genes that are just really complicated to diagnose, like specifically this gene that we see here, the hiding gene. This is a pseudogene, and so the hiding gene is located in chromosome 16, but there is also another gene that is identical in chromosome 1. So try to diagnose this hiding gene abnormality is really complicated, and most genetic panels are not going to be able to differentiate or diagnose that disorder. So moving to our next diagnostic test, we have nasal nitric oxide testing. So nasal nitric oxide is produced by the neuroendocrine cells and the respiratory cells, also your endothelial cells. And multiple studies have demonstrated that patients with primary ciliary dyskinesia have low nasal nitric oxide levels in the nose. Again, this is not describing anything in the chest or in the lungs. It's just in the sinuses and in the nose. Nasal nitric oxide levels can be measured in a non-invasive manner. We can see a picture here. We just place a little probe in the nose of the patient, and then we can collect the air that is coming from the nose and measure the levels there. This technique is very reliable, it's easy to perform, and we actually are doing it here on kids that are older than 4 years old. The only problem is that this technique is not approved at the FDA, so it is only available in very few centers in the United States and through IRB approved protocols. These are some of the screenshots of how the different measurements look. Let's go further. So this is kind of like the studies that describe the nasal nitric oxide levels in different populations. So here we have different levels of nitric oxide levels in the nose. This right here is normal people. So most people without any problems are going to have nasal nitric oxide levels that are higher than 200. People with primary ciliary dyskinesia are going to have levels below 77. And this is kind of depending on the defects. These are the parents actually of patients with primary ciliary dyskinesia. So these people are carriers of the mutation, and you see how the nasal nitric oxide levels are above 100 in all of them. And so of notice, not everybody that has low nasal nitric oxide levels have primary ciliary dyskinesia. People with chronic sinus problems, like for example cystic fibrosis, can have low nasal nitric oxide levels. And now we know too that some people with immunodeficiencies can have low nasal nitric oxide levels. So when we have patients here in our institution that have low levels of nitric oxide, we rule out those three things: primary ciliary dyskinesia, immunodeficiencies, and cystic fibrosis. The current cutoff for primary ciliary dyskinesia is 77 nanoliters per minute. As you guys can see here, so the triangle ones are the people with PCD, and you see there are a few people that may have higher levels. So now we know that there is a few people with primary ciliary dyskinesia that can have high levels, but the majority should have levels below 77. So limitations of this technique: the equipment is only available in selected research centers. The levels might be falsely lower in people that have cystic fibrosis, viral infections, nosebleeds, or immunodeficiencies. We know of at least 2 PCD genes that can have low normal levels. So usually they have levels of about 90 or 100. They won't be in the 200s or 300s. It will be low normal. And we really don't have normal values for kids that are younger than 5 years of age. And this is because younger kids don't have formed sinuses. So they can have low levels of nitric oxide just because their sinuses haven't formed, not because they have any disease. The main advantages: this technique is simple, is inexpensive, is very sensitive and specific, and you can have immediate results. So this is from the Primary Ciliary Dyskinesia Foundation, the diagnostic criteria. So as you can see, we have the major criteria that is listed here. And so in newborns, cytosine versus totalis are unexplained unilateral respiratory distress with at least one of the following: an abnormal ciliary structure via electron microscopy, or if you find 2 mutations in a PCD gene, or persistent diagnostic ciliary waveform abnormalities on high-speed video microscopy. We haven't really discussed that one yet. This is also not very commonly done, but it's starting to be present in some centers here in the United States. Children that are 1 month to 5 years of age, again, 2 of the following: either electron microscopy abnormalities or mutations. It's pretty much the same thing as this one, but then you start including here nitric oxide is not included at this age because, again, we just don't have normal data. And for older kids, just the things that we discussed earlier. Okay. Immunofluorescence. So it is very highly specialized. I'm really not going to spend much time here because it's really done maybe 1 or 2 centers, but it's a really good way to, if you know which protein might be affected and you can find some antibodies to that protein, you can actually test for it. But again, it's very limited to a couple of centers, and I don't know that we shouldn't spend much time in here, so I'm just going to keep going. Highest speed video microscopy. It actually gives you a good idea how the cilia is moving. So it's a nice functional test. And you can see here how this example here. Sorry, this is how the normal ciliary movement happens. So nice Cripps movement and organized. This is a kid that has primary ciliary dyskinesia, so there is disorganized movement and very slow. This one too, you see some cilia goes in one direction, the other goes in the other direction, so it's not as nice as the one. So it's a really good technique, but the problem is that getting the biopsies on the cilia, the transport, processing, all of that can be complex, and so you have to actually, to be more accurate, you have to grow the cilia, the cells. You get your cells from the patient, grow them in vitro, so you are sure that those cilia are healthy. And once they have been grown for a few days and they are healthy, then you can do the analysis. So this has limited some of the technique, because not all centers can do all of that. This is also non-FDA approved, so it has to be done through a research protocol. And but it's a really good way to just to try to. It's a really good way to confirm. If some of the defects that you have found translate into abnormalities in the movement of the cilia. So diagnosis. So what we do here is that in children that are older than 5, we start with nasopharyngeal site testing. If nasopharyngeal site testing is below 77, then we move to one of the confirmatory tests, which can be genetic testing or electron microscopy. If nasopharyngeal site testing is above 77 nanoliters per minute and there is low clinical suspicion, no further test is needed. If there is a strong clinical suspicion, then you will have to move to one or the other test. If the child is younger than 5, you can consider nasopharyngeal site testing, but again, we don't have normal levels for these children. So we may need to start with either a gene test or electron microscopy. If you do genetic testing, we prefer to do here whole exome sequencing over the panel, just because, again, panels have the limitations that we describe, and we're also interested in maybe looking for other genes other disorders that might be implicated on kids with recurrent infections like immunodeficiencies. If the initial test is negative, but there is a strong suspicion, then you'll have to move to a different test. Just going to move this, just a little bit of treatment. So there is really not much about treatment. These disorders are rare and it's hard to do clinical trials. Again, when you have more than 50 genes that can cause the disorders, there is a lot of heterogeneity on how the clinical presentations are, and that this can be challenging to do clinical trials. But we have done a few of them. And this first clinical trial is we tested azithromycin as a maintenance therapy to try to decrease the exacerbations and infections in people with primary ciliary dyskinesia. And this was a double-blind, randomized, placebo-controlled trial. And it was the first multinational trial done in patients with primary ciliary dyskinesia. And it showed that in people that had recurrent bacterial bronchial exacerbations or infections, a therapy with azithromycin 3 days a week for 6 months was well tolerated and decreased the number of exacerbations. So we used actually now azithromycin on our patients. So if we have a person that has had multiple need for antibiotics for chronic bronchitis, chronic sinusitis, or things like this, then we will consider putting this person on azithromycin to decrease some of the frequency of the infections. This is another clinical trial that tested hypertonic saline in patients with primary ciliary dyskinesia to try to just improve mucociliary clearance and decrease infections. But it was a double-blind crossover trial, and unfortunately we couldn't recruit as many patients as were needed to power the study. So this turned to be underpowered, and it didn't really show significant improvement in quality of life or any other variables, but they just highlight some of the limitations on trying to recruit for these studies and how difficult it is. This study was looking at the safety and efficacy of an epithelial sodium channel blocker in people with primary ciliary dyskinesia. So the idea was to try to get more hydration into the lumen of the mucociliary area by using this sodium channel blocker, and it was a phase 2 crossover study, and it actually showed improvement and potential benefit, especially when it was combined with hypertonic saline. So right now, a larger study is being planned to see if we can show that there's evidence now on a longer study and with more patients. So some promising therapies here. And then finally, I think we see that a lot of diseases are moving into the kind of a more personalized type of medicine, and this is one of the kind of we have seen this type of therapies also in other disorders, and it's expanding rapidly. So this is mRNA-based therapies, and this is the first study in using message RNA on people that has a specific mutation. I forgot which mutation it was, and but again, it's just very promising. I think that this is going to explode in the next couple of years on doing very personalized kind of type of medicine, specifically guided for specific genes, and delivering the medication to the organ that is affected. So, summary: cilia is a complex structure and has multiple functions. We talk about how there is primary cilia with absorption and sensory functions, the motile cilia and the nodal cilia. Ciliary problems can be inherited as autosomal recessive, but also they can be inherited as an X-link, and multiple organs can be involved. No single test can diagnose primary ciliary dyskinesia, but now we have a panel of tests like nasal nitric oxide, genetic testing, electron microscopy, and they're all complementary, and sometimes you need to do more than one test to either diagnose these patients or rule it out. There are limited studies on therapies, but we have some evidence that azithromycin may help decreasing some of the burden of bronchial exacerbations with bacterial bronchitis. And maybe some of the new message RNA therapies also might be available in the future. And so hopefully we can just have more for our patients and prevent some of the bronchiectasis, decreasing lung function, and also hearing loss that we see that is prominent on these patients. I don't know if anybody has any questions.